So what is the procedure is, we generally perform it at around S4 to S5 vertebra. Here you will find these are pediatric patients, so it is very easy to palpate sacral cornu in these patients. We will palpate sacral cornu. At the sacral cornu, we will pierce a small needle. We will hit the coccyx bone. We will hit the bone. Then we have to just turn the needle a little, and then you have to pierce few more millimeters so that you can find loss of resistance sensation. There we can administer local anesthetics. Approach is similar to epidural anesthesia, as we have learned. Preparation and position is same. Next, projection towards S2 vertebra. Advantages: there is no chance of spinal cord injury. Yeah, here the point is the spinal cord is ends at here in pediatric patients, we can easily palpate the sacral cornu. We will palpate both sacral cornu and insert a small needle just in the midpoint of sacral cornu. Like, for suppose you will draw a triangle joining the two sacral cornu. Just below this, at this point, you will introduce a small needle just to hit the bone inside. Then after hitting the bone, you will just rotate the needle direction and pierce few millimeters into it again. Then you can find loss of resistance sensation. There you will confirm it and you can administer local anesthetic. Site is around S4 and S5. Approaches same as in spinal anesthesia, preparation and position. Next, projection is towards S2 vertebra. Here, advantage, the most important advantage of caudal block is there is no chance of injury to spinal cord. Why is it so? Because in infants, spinal cord ends at L2 to L3 level. Here we are introducing a needle at S2 level. So there is no chance of injuring spinal cord. Next, coming to disadvantages, it is always used as supplemental anesthesia. That is, you cannot uh, uh, base on this caudal anesthesia for the whole surgery. It is just a supplemental analgesia. Next, so you have to give both general anesthesia and caudal anesthesia. You have to follow very strict aseptic precautions for this. And sacral anomalies can also be present. You might hit a piece of bone which can be painful and damaging to the ossifying center. Volume of local anesthetic used depends on Armitage formula. That is 0.5 ml per kg for lower limb surgeries, 0.75 ml per kg for lower abdominal surgeries, 1 to 1.5 ml per kg for upper abdominal surgeries. Next, these two are the most commonly used local anesthetics, bupivacaine and ropivacaine. Bupivacaine under a dose of 0.25% concentration at 1 ml per kg. Ropivacaine 0.2% concentration at 1.2 ml per kg. Recently, caudal catheters are also used. Next is the combined epidural and spinal anesthesia. We call it CSE. Here, this is the anesthesia of choice for prolonged surgeries. For example, lower abdominal or lower limb prolonged surgeries, we can go with combined spinal and epidural. Uh, this is done with the help of a special needle called CSE needle, standard Tiohi epidural needle. There are few needles where there is even a port for spinal needle also. This is the epidural needle, and here is the port for spinal needle also. In mild to moderate PIH, there will be combined and you can give combined spinal and epidural. In severe PIH or in eclampsia, we'll directly go for general anesthesia. This combined spinal and epidural anesthesia is used in labor analgesia also. Next, here, this is the special spinal epidural needle. Here, we have pierced the ligamentum flavum. This is the ligamentum flavum. We have pierced it and entered the epidural space. This is all the epidural space. So, we have stopped this. We have paused this epidural needle tip at the epidural space. Then we can advance the spinal needle to pierce the dura. So epidural needle tip is in the epidural space, and spinal needle tip, only that spinal needle can advance into the dura, so that through the spinal needle our local anesthetic can be injected into the subarachnoid space, whereas through the epidural catheter our local anesthetic can enter the epidural space.